Good afternoon. Michael Pencina here. I will be delighted to talk to you about taming the beast, the need for a thoughtful health AI governance. AI is a beast indeed, and it has run out of its cage. So now I don't think we can catch it and put it back in its cage. All we have to do right now, all that's left to do for us, is to tame it. I think we've all witnessed the unprecedented amount of interest and attention given to AI, especially in the last year since the ChatGPT technology became mainstream. AI has been around with us for many, many decades, but the attention it's gotten in the last year is just incredible. And that is very true in the health domain, where new algorithms, new tools are being developed as we speak. It offers tremendous opportunities, but also important pitfalls. So, when we talk about AI, what do we mean? Well, I like to subclassify it into two categories. One is the predictive AI, which is a little bit more known, and it's an area that I think we developed a fair amount of comfort. Predictive AI analyzes data to make predictions, right? So we look at imaging of, for example, breast mammography to predict development of breast cancer or identify breast cancer that might be hiding in these images, which may or may not be identifiable by a human eye, right, by radiologists looking at this image. Or we develop a risk prediction algorithm to assess the probability that an individual will develop cardiovascular disease in the next 10 years. An algorithm like this has been used over 20 years by the cholesterol guidelines to determine recommendations for statin treatments or other lipid lowering strategies. This is different than generative AI, right? What GPT can deliver. And generative AI can be used for predictive tasks, but generative AI, by its design, generates new content based on existing data. What does it mean in the healthcare context? Well, imagine an ambient tool that listens to your conversation with your doctor and generates a clinical note. Or imagine a tool that takes patient questions submitted to a doctor through MyChart or another portal and creates a proposed reply for the doctor to edit and send back, right? It's a generation of new content with healthcare application. I'm not going to mention writing essays, poems, and other things, but that's obviously possible as well. Now, generative AI and large language models can be further stratified based on the type of input, right? Structured input leading to natural language generation, and unstructured input leading to large language models. And then the tasks are further stratified, right, into summarization, Q&A, chatbot, and others. And then there are different examples beyond the ones that I've given. Now, we can subdivide AI or health AI through a different lens. So, based on the application of AI, there is a tremendous potential for applications of AI for discovery science and basic science research, right? So that's cell modeling, that's protein modeling, and so on and so forth. I think it's a very active area of development. Clinical AI, probably the most controversial, is using algorithms to aid doctors, nurses, or other clinical practitioners in making better decisions or recommendations, right? So I mentioned the mammography example with imaging or the cardiovascular disease risk prediction. Those are just a couple of examples of what's called clinical decision support based on AI. And the area that's probably developing most rapidly today is operational AI, making healthcare operations more efficient, right? When we talk to healthcare providers and patients alike, generally they don't complain about their doctors not knowing enough, right? It's my experience talking to patients; they're very happy with their doctors, especially Duke doctors or nurses, right? Once they get to see the provider, they're extremely happy. What they are not happy with is the operational components of it, right? It's the hassle of scheduling an appointment or having to wait in an emergency room. Happened to me, 6 hours for admission, right? So how can we make the process of healthcare delivery easier? There are issues related to medical coding and billing, right? All the things that we as patients don't see that can be greatly improved with the use of AI. Now, I started with a beast, right? Here is another analogy. So we have a beast running in a wild west of algorithms. I will say everybody on their computer, maybe in their garage, is developing a new AI tool with the hopes that it might change the world. And there are so many vendors and developers excited about the new products that they can create and very eager to sell them to healthcare providers, directly to patients, and in all different ways of activity. Unfortunately, majority of these products are not good, right? They are developed by people who are maybe well-meaning, maybe seeing the shining gold opportunity and trying to get rich quickly. Whatever the motivation, they often lack the context and understanding of operations of health systems and the clinical delivery enterprise, right? So we have the Wild West, and then regulators are trying to catch up into this space, but it's hard to legislate and regulate in a meaningful way in a field that is so new. So it's really on us as researchers, as health system representatives, as patients, as responsible citizens to work together to make sure that there is value, quality, as well as ethical principles are implemented and health equity considerations are taken into account. And if we don't do that, AI will fail in the field. And this is not just apocalyptic predictions that the end of the world is coming with AI, and it might have that potential somewhere there, but there are more real, tangible problems, right? The articles I'm showing here are just two examples. One is describing racial bias in an algorithm used to manage the health of populations, right? This algorithm was supposed to identify individuals that need additional preventative care. When examined based on true health status, right? So the researchers took the algorithm, applied it, and looked at, okay, which individuals would be eligible for preventative care using this algorithm. The answer was about 18% of Black patients were eligible. When the algorithm was examined, taking into account their true status, their true need of these preventative services, the true percentage should have been 47%, right? So enormous amount of bias that occurred in that algorithm. Turns out the developers used a proxy instead of taking into account the true health status. They used health system interactions of their patients to develop the algorithm. Well, individuals from historically marginalized and disadvantaged backgrounds don't have the same access to healthcare systems, so they interact with them less. And that led to this enormous bias in the algorithm. A different problem was shown in the other article that I'm showing. And Epic, which is a big electronic health record vendor, had an algorithm to predict the risk of sepsis. And my colleagues at Michigan have shown that the performance of that algorithm is not satisfactory in their health system, right? We don't have one algorithm to rule them all. It may not work in other fields, right? So here is the graphical depiction of the problem with the first algorithm I mentioned. When you look at the risk according to the algorithm based on percentile, right, and then you look the true number of active chronic conditions, we see that the true number at any given level of risk, the true number of chronic conditions is higher in black patients than white patients, even though the algorithm assigns them the same risk. That's a problem. And the second graph shows that the true level of risk should have been much higher for Black patients than assigned by the algorithm. In response to that work, we published a paper, a perspective reminding algorithm developers of the criteria that they need to use to develop tools that will be clinically meaningful and useful. We also made this prediction in 2020, right? So this is before the deluge of large language models, that given the number of emerging prediction models in their various applications, no single regulatory agency can review them all, right? That's a really important statement in the sense that we're basically saying whether it's FDA or any other regulator cannot handle the deluge of algorithms. We said in 2020, now we're in 2023, right, in the era of large language model revolution, and this statement is even more true than it was 3 years ago. So it's a call to action. So here are the principles that we outlined in this perspective, right? We need to think about the population at risk, the outcome of interest. So population of risk, who are we applying this algorithm to? What is the outcome of risk? What are we modeling? The duration of follow-up, time horizon. What are we going to use as predictors? What's the mathematical model? How fancy it is. The evaluation metrics of the algorithm itself, and then translation of the algorithm into clinical decision support, and then clinical implementation. How do we make sure the algorithm that was developed doesn't stay in what I call a parking lot of algorithms, but truly is used to improve healthcare? So let's dig a little deeper into these categories, right? Population at risk talks about individuals to whom we intend to apply this algorithm. And as you know, this is not always the same as the development population. A lot of algorithms are developed on what's called convenience sample, right? It's a subset of data that happens to be available to the developers. And you hear examples of algorithms being developed based on data available on the internet, right? And it might be predominantly Caucasian or white individuals getting their data into the algorithm. And then, not surprisingly, the algorithms perform better in that population, even though the intention is to deploy it across different racial or ethnic backgrounds. So we need to consider factors like demographic status, health status, location, and the clinical context. One example I like to use, another biased algorithm. If you wanted to develop an algorithm to predict some condition in young women, and you took a sample of young women who interact with the health system, you would have a very biased sample because in younger age, the primary reason that women interact with health system is pregnancy, right? So you would be developing algorithms on pregnant women, and we know that during that stage, their health status is different, and they are not representative of the population for whom we might want to have the algorithm. So examples of the population at risk, and I will carry through all these considerations, it's contrasting two risk algorithms using very different AI tools. One is the pooled cohorts equations for cholesterol guidelines. Mentioned that these have been in use for quite some time, where I think we have a third or iteration of an algorithm that the guidelines are using right now. right? So it's individuals age 40 to 79, pretty broad age range, free of cardiovascular disease, and developed on National Heart, Lung, and Blood Institute cohort of about 25,000 participants. That's different than an algorithm we're using in our healthcare system at Duke, predicting the risk of sepsis. That algorithm was developed on a Duke patients admitted to emergency department at Duke based on over 42,000 encounters over 14 months. So now the outcome. Outcomes need to reflect the primary focus of care. Use of surrogate variables, as in the example I shared, may lead to unintended adverse consequences. Outcome data needs to be well curated. It's not the size, it's the quality of the outcome data. And that's very important. A lot of people like to say, if I have enough data, the quality of the data is not going to matter. That is not true. Published a viewpoint in Stat with the title Big Data, Big Mess. The more data you have, the more consequential issues with data quality will be, especially as it relates to outcomes. And then we have competing events and other considerations. Now, the example, the outcomes of interest for the pooled cohorts equations that drive cholesterol guidelines, it's cardiovascular disease, so heart attack, stroke, or cardiovascular mortality. For the sepsis algorithm, it's defined using generally accepted criteria: abnormal vital signs, suspected infection, and at least one sign of an organ failure. Duration of follow-up takes into account the starting point, and then how far do we want to go into the prediction. Prediction window that's too short might improve model performance, but be less clinically actionable for outcomes that develop more slowly. So going to our example, 10 years after baseline measurement is usually used for cardiovascular disease risk prediction, but guidelines suggest longer-term algorithms for younger adults might be better, because 10-year risk of cardiovascular disease for younger individuals, especially women, will be very low, oftentimes less than 1%, giving them the false comfort that they are okay. Whereas changes might be happening to the arterial wall, right? Deposits of cholesterol might be creating plaque, which increase the risk of cardiovascular disease, and the changes may be irreversible. So if you wait with appropriate treatment till age 60 or older, it might be too late to get you to a health status that could be attained if appropriate interventions started earlier. And this intervention might mean lifestyle interventions. And very different story with the sepsis algorithm. 4-hour window. Predictions made every hour, right? So here we're talking about decades for predictions for cholesterol guidelines versus hours for sepsis prediction. And then we have choices of the starting point. Is it the emergency department admission? Is it inpatient admission? Is it intensive care, right? So there are different choices at every step. So what goes into the algorithm, right? How do we choose predictors? What matters is the ease and time of collection. Questions of, are the predictors biased, or are we not including variables, or including variables that might relate to bias, right? There is a discussion and controversy about inclusion of race in risk prediction algorithms, and the general consensus that's emerging is to avoid inclusion of race, because the belief uh, uh, based on scientific evidence is that race is not a risk modifier in its own right. It might be a proxy for other factors, but as such should not be included in an algorithm. What's the impact of using the algorithm on health equity? How stable is it, and how much we can interpret? For predictive models, it's important to have some understanding which predictors drive the results. That statement of comfort does not scale well into generative AI and large language models, right, which were developed using the internet. And so it's harder to answer these questions. But I think on the predictive models, we should still strive to understand why they are doing what they are doing. Going back to our example for cholesterol guidelines algorithm, we have age, smoking status, diabetes, blood pressure, and blood pressure medications, as well as total and HDL cholesterol. Models are run separately for women and men, and the algorithm that I'm referring to had separate models for black and white individuals. That was developed in 2013. There is a new version just released by the American Heart Association that I participate in development, which actually removes race from the algorithm. And the sepsis algorithm, 35 baseline predictors, 34 time varying physiological variables, 10 medication classes, over 32 million data points to build it. Now, the fun part, the mathematical model. So performance needs to be balanced by the ability to understand what drives it and also by ease of implementation and maintenance. I like to say that the burden of proof should be on the more complex models. There tends to be a trend nowadays for investigators who like to develop an algorithm that's as complicated as it gets. And there are different reasons. Some people just like being fancy, others like to hide their IP behind the algorithm. When I review scientific publications, I always ask developers that use more complicated algorithms to show to me that their task could not have been achieved with a simpler model. Reproducibility and transparency are necessary, and black box solutions are hard to evaluate and can lead to implicit bias. And again, we're starting to learn potential biases that ChatGPT might have, right? If you experiment with it, you will start seeing these issues. But fortunately, developers are working on correcting them, right? So that the GPT era adds another question: what do we do in an era where the algorithm is inherently black box? Our example, the mathematical model. So the pooled cohorts equations for cholesterol were used using the Cox proportional hazard regression. It's a simple model. I think some people would still call a regression an AI technique, as opposed to the multitask Gaussian process recurrent neural network classifier used for the sepsis algorithm, which is much more complex. In general, based on our experience in real applications simulations, uh, you don't need complex model for simpler data, right? So the complexity of the algorithm that's needed relates to the complexity of the data that's available. If you have curated clinical data sets, simpler models will do just fine. On the other end of the spectrum is natural language processing and image analysis, or combination of these modalities that can really derive added value from more complex algorithms. Now, the evaluation of the algorithm should be performed on data other than the development set, right? And on data on which we intend to have the application. Temporal validation is often useful. So what I mean by that is we develop an algorithm on data that goes from, I don't know, 2013 to 2015, and then validated it on data from 2015 through 2018, right? And hopefully that development happens in 2022 and validation happens in 2023, right? So it's kind of as close to now as we have access to. Model discrimination refers to the ability to separate between those who do and do not develop the outcome or have the outcome. And model calibration refers to the closeness between predictions and observed reality. In our example, the pooled cohorts equations, the model was validated in the development cohorts as well as numerous external samples. And the Duke sepsis model was validated on 32,000 new encounters and compared to another algorithm called National Early Warning Score for sepsis. Translation to clinical decision support, right? So it doesn't stop with the algorithm. The critical piece is to take the algorithm that does predictions or something and build it into the workflow. right? So if it's a predictive algorithms, we might want to intervene on individuals with the higher risk or apply different strategies at different levels of risk. The clinical decision support needs its own evaluation. We might need to compare it with the current practice, ideally using a randomized experiment and taking into account health equity. So in our example, pooled cohorts equations, the clinical decision support is defined. Lipid-lower treatment is recommended to individuals whose 10-year risk of cardiovascular disease is equal or greater than 7.5%. And that's what the guidelines for cholesterol have come up with, right? And we model implications of this clinical decision support using nationally representative survey data. In the sepsis example, risk is categorized as presence, high, medium, or low, and there was a trial planned to connect it to the bundle compliance as primary outcome. So the performance metrics, discrimination, right, separation of events and non-events, and I'm listing a few statistical metrics that are commonly used. Calibration, closeness of predicted unobserved risks, and that can be evaluated using graphical displays, calibration in key subgroups, and it can actually be useful for detection of bias, right, looking at different subgroups. And then the clinical decision support tool can be evaluated using sensitivity, specificity, positive predictive value, negative predictive value, net benefit, relative utility. These are different metrics, net benefit curves, and different weighted metrics that put a different weight on missing a future event versus recommending for treatment a expected non-event, right? And if you jump to large language models, that becomes much more complicated, and we have less experience with evaluation of these algorithms, right? So right now, I see a lot of evaluation done in a human way, right? So you give the note that was written by ChatGPT and have a human read it and score it, or you have a human written gold standard, so to speak, and you compare how close what was created by GPT is to the human gold standard. And these metrics are in development. Unfortunately, every time I see a large language model evaluated or described in a paper, it uses a different performance metric, which makes things more complicated in terms of comparisons, right? And then some evaluations are context dependent, or metrics can factor in the context, training, as well as the level of granularity, right? Is on the character, word, or embedding level. The effectiveness evaluation itself should take into account either clinical, operational, or financial outcomes. Study designs, ideally randomized or at least pseudo-randomized, matched or adjusted. I think oftentimes you see the pre-post comparison, which is actually the weakest form of evidence because we have no control over factors other than the algorithm and the workflow that might affect performance. So we don't really know if we're evaluating the value of the algorithm. And then we need to consider impact on health, health equity, patient satisfaction, cost, and other metrics, right? And this is real. I showed you the early example from the biased algorithm. We have another example of an issue with an algorithm that we published early this year, looking at 10-year risk prediction of stroke, where the graph on the left shows the 10-year risk of stroke as a percentage, right? So you see black women have risk higher than white women, and black men have risk higher than white men. And here is the discrimination C index, how well the algorithm separates those that have events from those who don't. And as you see, the performance is weaker in black women compared to white women, and in black men compared to white men, right? So we have higher risk in black individuals compared to white individuals. Performance of an algorithm is worse in black individuals compared to white individuals. Clearly undesirable feature, and we don't quite know why it's happening. We tried advanced AI algorithms to improve the performance, but they didn't help much, and so we're working on new methods to address the issue. Finally, clinical implementation, while it's the last step, it should drive decisions made in all previous steps, right? So it's really permeating the entire process. Users need to embrace the tool's value to be willing to use it. That's a kind of somewhat obvious statement, but in reality, the reason many algorithms are not being used is because users have not embraced its value. They don't trust it, so they don't want to use it. So the clinical implementation is so important, having the future users incorporated in the development process. Implementation will not happen without incorporation into clinical workflows, right? We have to train and performance engineer to understand the appropriate use, and then regularly monitor to assure quality and enable necessary adjustments. Right, and in my example, the calculators on the American Heart Association and American College of Cardiology websites, and the algorithms are programmed into several electronic health record systems. And at Duke, the clinical decision support is programmed into Duke electronic health record system. So those are the principles. Now, what does it mean in our actual health system application? So at Duke, out of primary focus on patient safety and high quality care, we formed the algorithm-based clinical decision support governance system. We call it ABCDS, really focused on evaluation and monitoring of AI and other algorithms, right? So what we saw is a lot of vendors knocking on the door of the health system, trying to sell their products, telling us that it's going to do wonders for patient care, and having very little data to support it. And so to prepare ourselves as a health system, we formed this ABCDS. And again, this was formed about 2 years ago, and I joke that this is the oldest health AI governance system in the country. It's 2 years old, right? This is a very new field, and Duke is leading the way with having the process in place. And with the commitment of health system leadership, we are a health system where no new algorithm will be employed on Duke patients until it goes through a thorough review according to the process that we established. Right? It's a complex environment. You think it's kind of health systems run like machines. That's not the case. There are different skills of individuals, doctors, nurses, administrative workers, right? And then data scientists, informaticists, working on trying to improve care in building these algorithms. But they come with different knowledge bases, and they have different resources available. And the project teams differ from project to project, right? So that all has to be taken into account so that we can have a useful algorithm ready for the clinical workflow at the end. So our governance process was built based on what the Food and Drug Administration does with medical devices, right? So there are four major stages: the model development, which mirrors the pre-human development phase for devices. We have silent evaluation, so the algorithm performs well enough on retrospective data that we can program it in our health system without showing the results to the clinicians. If that looks good, we go to the effectiveness evaluation. That's where I would like to have randomized experiments, as many of them as possible, to compare, again, not the algorithm itself, but the strategy that is driven by the use of that algorithm to current practice. And if that looks good, we go to general deployment, right? Putting it into the workflow of the health system. At every stage, we have these gates where the evaluation governance team meets, and makes a decision if the data available to us is strong enough to send the algorithm to the next stage. And then we have multiple gates after general deployment that facilitate continuous monitoring, right? So at the first stage, the evaluation happens on retrospective data. After the silent evaluation, it happens on prospective data, then evaluation on pre-specified outcomes in hopefully a randomized experiment, and then evaluations at regular intervals. We also register the algorithms in the process, and that's very important differentiator for Duke. I like to argue that there is no transparency without taking an inventory of what you have running in your health system. And again, a lot of the concerns relating to AI relate to the fact that you may not know how it's being used, right? So if we register it, we start transparency of what's happening. We take a risk-based framework where algorithms that are considered standard of care go through the registration, but only technical validation through traditional clinical decisions for implementation process, versus the most complex data-driven algorithms go through a full-scale evaluation. It's a process that takes a lot of people to be a part of it, right? So that's just a snapshot of some of the committee members, and they're by no means all the people involved across the spectrum, right? Importantly, we have the ABCDS oversight, and then we have regulatory subcommittee helping us decide should this algorithm be sent to the Food and Drug Administration for their evaluation. We have the evaluation subcommittee, which helps us determine if the algorithm should move from one stage to another, and then implementation and monitoring subcommittee, which is helping us to see what's happening with the algorithms as they're being put into production and are operating in production. And this is not just an academic exercise. We have about 62 active algorithms at different stages of monitoring. 43 of them have been registered, right? And the diagram shows different areas where they operate. So this is not just at Duke and for Duke. After we built algorithm-based clinical decision support, we got together with like-minded partners at different institutions nationally, Mayo Clinic, Stanford, Johns Hopkins, and others, and formed the Coalition for Health AI. This is a coalition started with health systems, but then we invited industry partners representing algorithm developers or technology developers. We invited government representatives from all government agencies that touch health, so the FDA, Office of the National Coordinator, CMS, NIH, to join the Coalition for Health AI to really build guardrails and best practices for trustworthy AI in health. And the response has been overwhelming, right? CHAI, Coalition for Health AI, started less than 2 years ago. Right now, we have over 800 institutional members, over 2,000 individuals participating and donating their time to the task of building trustworthy health AI. So in April of this year, we wrote a blueprint for trustworthy health AI. So CHAI created that document. It takes the NIST framework and adapts it into healthcare, pointing out the critical domains in which we need to operate to make health AI more trustworthy, right? And it starts with safety, kind of a patient-first approach, making do no harm, right, which is a key principle in medicine. Then it goes to the question of usefulness, right? Is it valid? Is it beneficial and effective? Can we test it? Is it reliable and robust, and is it usable, right? Will clinicians want to use that algorithm? The issues of fairness and equity. How do we make sure the use of AI does not exacerbate health inequities, but leads to better and more equitable care? The issues of privacy, security, and resilience, right? So making sure that patient data is protected in the process, that's very important in the context of GPT and similar technologies. That issue is front and center in the presidential executive order that was signed at the end of October. Explainability and interpretability. What does it mean for predictive algorithms? What does it mean for technologies like GPT, which we can't fully explain how the predictions were generated? And then accountability and transparency, right? What's the visibility of what's happening? I talked about registration. That's one important step on the road to transparency. So now we're working through the Coalition for Health AI with the original founders and then government agencies and representatives of industry on these best practices, right? So we've taken these 6 pillars that are listed here, convened work groups, which are taking this from a level of principles into a level of applications, right? The question becomes, how do you make these principles real in health systems across the country, with the understanding that we care not only about health systems like Duke, which are well advanced, have access to top clinicians as well as top scientists around, and so we can have robust governance, but what do these principles mean for rural or under-resourced hospitals or hospital systems, right? What does governance of AI tools mean? Because there is another layer of potential health inequity, which is based on geography and the health system. I think it would be very unfair nationally that patients that go see providers, health systems like Duke have state-of-the-art protections because we developed them, and patients that live somewhere else go to their health system, which doesn't have the means and resources to have solid governance, right? And they rely on whatever vendors are trying to sell them, right? That's a kind of health system level inequity that we should try to avoid, right? And the question is, what is the model of the governance? So we're working on taking the Duke governance as well as working with our partners in the Coalition for Health AI in trying to define what scaling of this process could look like. So I think I'm going to pause here and see if we have any opportunity for questions from the audience. Thank you very much.